Welcome to Global Dispatches, a podcast about foreign policy and world affairs. I'm your host, Mark Leon Goldberg, editor of UN Dispatch. And in this show, we discuss topical global issues, have conversations with foreign affairs thought leaders and newsmakers, and give you the context you need to understand the world today. Go to globaldispatchespodcast.com to learn more. And now on with the show. In 1976, Peter Piot was a 27-year-old microbiologist working in Belgium when he traveled to the Democratic Republic of Congo, then called Zaire, to investigate a particularly deadly disease outbreak. He took samples back to his lab and was among the team that first discovered the Ebola virus. Today, he is one of the world's leading experts on epidemics and infectious disease. This includes HIV/AIDS. In 1995, he was the founding director of the United Nations Program on AIDS called UNAIDS and served in that role until 2008. He is now the director of one of the world's most prestigious health research institutes, the London School of Hygiene and Tropical Medicine. And on the podcast today, we talk about epidemics and what can be done to avert and contain them. This includes the ongoing Ebola epidemic in the eastern part of the Democratic Republic of Congo, which is now the second worst Ebola outbreak in history. We also discuss what the world has gotten right and gotten wrong about both fighting HIV and AIDS and how we might need to redefine what we mean by ending the AIDS epidemic. We kick off, though, discussing the kind of nightmare scenarios that most concerned Peter Piot. This includes what he calls the big one. This is a great conversation with a true legend of global health, and I am so extremely pleased that today's episode is brought to you by Northwestern University's online master's program in global health. You can learn how to make a meaningful difference in places where it is needed most. Go to globaldispatchespodcast.com and click on the ad to learn more, or go to sps.northwestern.edu/global. And now here is my conversation with Dr. Peter Piot.
One thing is certain, I think, and that is that 100 years ago we had the Spanish flu, which killed between 50 and 100 million people when there were only 1.5 billion people on this planet. And one day we'll have something similar in the sense that we'll have an influenza virus that is completely different from the viruses that we've been exposed to, and against which we have zero immunity and protection. And since that's airborne, so that will happen. That will be produced in nature, maybe in poultry or in some birds or in pigs or whatever, so in animals. And when that hits humans, then and it's airborne, then we can go for another real catastrophic type of epidemic. And so when will it happen? We don't know. It's like, I was just in California, and we say there's about the big one. The big one is the big earthquake. It can happen tomorrow. It can happen in 100 years. And it's a bit similar for this new type of pandemic flu. And that's, that's number one. A second one is a bit maybe going into slightly science fiction, but I've been thinking a lot about that. And that is that, okay, with climate change, we're going to see the permafrost and be, defreezing. And that could liberate some microbes that are either entirely new, against which we have no protection, or pathogens that could also create a kind of an out of control epidemic. And then there is always the unknown, what's called pathogen X. But so these are some of the I think scenarios that are not unreal. And I'm not a doom thinker or a pessimist, but we need to be prepared for it. And it's particularly anything that is airborne. But let's not forget that at the end of the last century, what popped up as what is now the biggest epidemic of our time, and that's HIV, a classic sexually transmitted agent that now cumulatively has already infected well over 70 million people and killed over 35 million people. We don't think about it that way, but that was completely new. That's not airborne, fortunately, and it's because it's sex transmitted through sex. It's a underground, and it illustrates how human behavior is really the carrier of pathogens.
So I do want to speak with you about HIV in a little bit, but I'm intrigued by your response to that sort of kind of doomsday question that I've asked other public health experts in the past, and they do always cite that sort of the influenza scenario. But it's interesting. You're I think the first microbiologist I've spoken to and described a permafrost scenario of a microbe being released into the atmosphere. I mean, how plausible is that to you?
Well, I think that there are already signs that from permafrost we've had an outbreak of anthrax. So I think in Siberia, so that was from a cadaver of an animal that was carrying that and was frozen. I think it will happen, but whether this will be more of local importance, like local outbreak, or will give rise to a big epidemic, I don't know. I mean, I think it's highly unpredictable.
So it seems like the unpredictability of both the timing of, like, say, when the big one will happen, or this kind of permafrost scenario, suggests to me at least that, the world needs to sort of race to prepare itself to confront these sort of scenarios. How prepared are we, and sort of what does, global, epidemic preparedness look like today to you?
Well, certainly compared to 100 years ago when we had the Spanish flu, we are much better prepared. There's no doubt about it. We've got better tools. We can now diagnose a viral infection in an hour or two. Before that would take sometimes weeks. We've better diagnostics. We also have antibiotics, even if there can be a problem of resistance, but against these antibiotics. But it's many people during an influenza outbreak die actually from pneumonia, so that can be treated by antibiotics. We've got some vaccines. Certainly, they're not perfect, but for influenza, we've got vaccine. We've got even a vaccine against Ebola now, 2 vaccines. So we're better prepared. But on the other hand, we are hugely mobile. Millions of people take a flight every day. And what in the old days, if you get infected in, let's say, Hong Kong with some new strain, you had to take the boat, and it took a few weeks before you're, let's say, in London, where I'm now. Today, that's just an overnight flight. And so highly densely populated. I think also with global warming, we've got more and more mosquitoes that can multiply what used to be climate, temperate climate zones. So that's all, on the negative side. And I think there was a report that was just published from the Global Pandemic Preparedness Monitoring Group, I think it's called, with the World Bank and the World Health Organization. And their point was that the world is not prepared. Is not prepared enough for a massive outbreak. And I think we need to distinguish between 2 things. One, we cannot prevent outbreaks to happen because the origin are viruses, pathogens coming from animals. These are so-called zoonoses. And so we can't prevent the first case of Ebola, let's say, because the people are infected from a virus that comes from bats. What we can prevent is from an outbreak to become a large epidemic. So that's the first thing that we can do. And that's where early diagnosis and being prepared on the ground is so important. And we often talk about, international teams, the global response, but what's most important is the local response and local preparedness. When in 2014, it took more than 3 months to find out that what was going on in West Africa was an Ebola outbreak. Because there's no infrastructure, no laboratories, and in any case, nobody was looking for Ebola in West Africa because we thought that it was only happening in Central Africa. So that local preparedness, I think, is really this for my number one concern for just preventing a local outbreak to become bigger and bigger.
On this question of local preparedness, what does that look like to you? What's involved with that? I mean, is it a matter of, say, training frontline health workers or scaling up national laboratories? What are elements of the kind of local preparedness that you see could be a useful tool in preventing or halting epidemics?
Yeah, I think that the first place it is to have systems and infrastructure for what we call epidemic surveillance, and where there are laboratories and people who collect the data and who can detect when something abnormal, something risky appears. And that's a combination of people, skilled people who do that and who know what's going on in the community, who collect the data, who collect biological samples for testing, and where that can be analyzed and so on. And that's something that, like in the US, you have the Center for Disease Control, and every state has that. It's the same in the UK, and South Africa has that. But many of the most vulnerable countries, particularly in Africa, don't have such a system. And it's really, when you look at health budgets, it all goes to hospitals and healthcare, and rarely to this kind of supporting that system and infrastructure. That's the first thing. And then secondly is very good communication. People need to know, and that's an advantage of today, where we have so much better communication means, but they can also turn against epidemic preparedness by spreading false rumors and fake news and so on. But that can be managed. So that local preparedness is really important, and it costs money. But it's like, what we do today is that we wait until there's an epidemic and there's Ebola and so on, and then, we put in all the resources and so on. It's as if we only set up the fire brigade when a house is on fire. No, we need that preparedness and working on that when there is no outbreak, no epidemic, and that costs money. So it's a matter of investment that we need. And then secondly, another issue is that for example, to prepare for a respiratory type of virus like influenza, is preparing health services, hospital, through exercises like a fire drill. What if suddenly, the number of patients who knock at the door of the emergency room or in the hospital, pneumonia and so on, if that multiplies by 10 or so? How are we going to cope that? And that includes also, of course, healthcare workers who themselves will be affected. So that going through that kind of preparedness drills is equally important.
On Ebola, which you mentioned earlier, we're speaking in the midst. It's now over 2 years of this outbreak in the eastern part of the Democratic Republic of Congo. Is this current outbreak teaching you anything about Ebola, the virus, or how effective response could be mounted that you didn't already know?
Well, in theory, we knew it all, but in practice, what the outbreak in the DRC, the Ebola outbreak, is showing again is that you don't operate in a vacuum when you're dealing with epidemics. It's on the one hand, the insecurity situation with armed conflict and so on, and that's one thing, with lack of trust in government, and community mistrust. That is actually very easy to understand as far as I'm concerned. So it's not just about Ebola, but it's a lot about other things. And I think the mistake initially was perhaps that we had not, we collectively not listened it carefully enough and not worked with communities, what people were thinking from day one. And that was one of the big lessons from the largest Ebola outbreak in history in West Africa. So that, I think, is a big issue. Dealing with epidemics is not just a technical issue. Okay, we've got a vaccine, but if people are dying in the community, are hiding, or are not, you can't reach certain parts of a community because of security issues, you can't vaccinate them. So the vaccine won't work if you don't give it. And also when people feel that they've been neglected in terms of their health needs for generation, basically, in the case of Eastern Congo, and they suddenly ask, why is all this money coming just for one disease? So we need to have a more comprehensive approach. But the good news is that, for example, today we do have 2 vaccines that can be used to protect you from Ebola, which we didn't have before. So there is progress, and also there are far more people with that experience who know how to manage such an epidemic.
I guess what's sort of interesting and sort of disturbing to me is that, you mentioned experience. I mean, DRC has experience and, fairly sophisticated ways of confronting Ebola. Yet this outbreak seems so stubborn. The World Health Organization and international organizations now have these new tools at their disposal and reforms of the WHO following the West Africa outbreak. Yet we still have this enduring Ebola outbreak, and there seems to be like no end in sight at this point.
Yeah, the current Ebola outbreak in Democratic Republic of Congo has been going on for now 15 months at least. And whereas the number of new cases is going down, is fewer than before, but still like 2-3 a day, which under normal circumstances is a reason for being extremely worried. And here we say, oh, it's only 2-3 a day. And it is moving to some other areas, with community deaths, which means that there are, this transmission going on in the community. So, and the reason I think for that is it's not a technical one, because the vaccines are being there, and there's a real deployment of lots of contact tracers and treatment centers. From the national side, the National Institute for Biomedical Research, from Doctors Without Borders, from World Health Organization, the London School of Hygiene, Tropical Medicine, we're all there. But it's about much more. And I think that we've also been extraordinarily lucky that this has not spread into one of the big towns, from Goma to Kisangani, even Kinshasa. Because one person who moves and who is not, let's say, treated and isolated in going in a big city can really give rise to a very serious epidemic. So we have to intensify our efforts, but at the same time, we're now trying also as a national and international actors there to provide some decent healthcare for other problems, because people are dying from malaria, kids are dying from measles, because vaccination is not going on. So you can't look at just Ebola and say, okay, the rest is not my problem.
How long do you expect this outbreak to go on for?
Oh, well, that
if there's anyone to ask, it would be you, sir.
Well, in February, when we thought, and WHO said, oh, that's nearing the end, and because the number of cases are going down, and so we've been there before. I frankly think it can still go on at this relatively lower level for several months, but I think the lesson that I've learned is that to not make predictions, because there can be a resurgence and so on. So, but we should not be complacent and think that, okay, we're nearly there. No, That's not going to happen.
So I'm glad that earlier you brought up HIV/AIDS. What do you currently see as the trajectory of the disease? And do you think that that 2030 target of ending the epidemic is feasible?
Well, there are these UN goals of 2030 elimination of or ending its epidemic, regardless how we define it. And then there are for 2020, in other words, in a few months from now, there are goals, to reduce the number of new cases to a certain level and so on. And it's very clear today that there's no way that we're going to reach the 2020 interim goal, and that and that should be seen in a context of a few points. One, we've made extraordinary progress against HIV. From the mortality, the number of people who died has been less than halved from 2 million, and now it's about 700,000 per year. But that's still a lot of people. The number of new infections has come down also, but it's still like 1.7, 1.8 million every single year. So we are far from the end of AIDS, and I think that we need to redefine what we mean by it and be a bit more realistic. I expect that some countries will do very well, and they're really on the way to very low levels of new infections and low levels of mortality from HIV. But then a neighboring country can be in trouble, and you can even see that let's say in the US. I was last week in the Bay Area in San Francisco, and in San Francisco, among white gay men, there's a very low incidence of new infections of HIV. You cross the Bay, you go to Oakland, and you have an epidemic that's quite out of control, particularly in African Americans, both gay men and in heterosexuals. So that illustrates dramatically, I think, what is going on in the rest of the world. And when you are in KwaZulu-Natal, for example, in South Africa, where our school is working a lot with the University of KwaZulu-Natal, and as a young woman, your risk of becoming infected with HIV today is still 4 to 7% per year. Can you imagine? That means by the time you're 40, nearly half of the women are HIV positive. So we still have a long way to go. Good news is that the Global Fund, Fight AIDS, TB, Malaria, they had a very successful replenishment round. And that is something that is essential, because without money, there is no way that you can, you can fight this. It's and we need to assure that there is, people remain under therapy, but also it is not just a therapy treatment that's going to do it. Because of this rhetoric about the end of AIDS, I think some people may think, oh, it's done. And there's quite some complacency. Also, because thanks, it's a price per sex. Yeah, go ahead.
Well, may I ask? I mean, earlier you said we need to redefine what we mean by ending the epidemic. What did you mean by that?
Well, I mean, it's clear that eliminating HIV, just because that's the end of AIDS, I don't think that's not going to be possible. Only smallpox has been eradicated as a human infection. Polio, we are close, but we are not there yet. And I think there will be a few other like so-called neglected tropical diseases that we may be close to eliminate. And trachoma in many countries is out of the world. So that is it is possible. But with HIV, where we have sexual transmission, where we have a chronic infection, there's no cure. The treatment is not a cure. So I think it's unlikely. So we have to set some goals, I think, for each country. Global goals for this for me, is pretty meaningless for when you are living in wherever, whether you're living in the UK or in Malawi or, or in Zimbabwe. And so each country should define and set very ambitious targets and working towards that and how to do it. And that is going to be very important because how you do it is going to be quite important for the in order if we want to have results. So that will be the way to go, I think. And one country that is, for example, that is doing quite well is Kenya, which is now a very decentralized country where each county has it's their own policy and budget, but the National AIDS program has designed tailor-made programs for each county in function of where the epidemic is. And for example, in some it's more more generalized epidemic with lots of young people and women, and others are for more where you can have where commercial sex or where men have sex with men may be more affected. So that's what we have to do. But it's not over, and all we can do is to redouble efforts, but pay more attention to prevention and not just all this attention for treatment.
Okay. Well, lastly, is there any new research coming from your school that you'd want to plug that you think listeners should be looking out for?
I think in terms of HIV, there's very important research on developing an HIV vaccine, because that's what we will need to really end this epidemic. And there, it's been very disappointing. Many attempts have been made, and it hasn't worked. But now I'm more encouraged that this is not coming from our school, but that there are studies going on with vaccines that may show results. But we've learned in the past the hard way that it's not because it works in non-human primates that it works also in in people. Now the other thing is that we need to understand much better the dynamics. Why are young women for example, in KwaZulu-Natal, as I mentioned, still infected? At this high rate. What's going on? Understand these dynamics, because that's what we need to have effective interventions. But on the other hand, it's also policy. I mean, it's in the countries of the former Soviet Union where you still see an increase in new infections. And that is a policy issue because the governments don't want to deal with it, or are just having discriminatory practices or a police approach to HIV because they're homophobic, or it's about drug users and so on. So that's not a scientific issue. That is a policy issue. And then going back to epidemics, it was announced today that a second Ebola vaccine, so the Merck vaccine, has been deployed as in ring vaccination in DRC, and with over 200,000 people vaccinated. Today is announced that we, as a coalition with the Congolese authorities, Doctors Without Borders, the Coalition for Epidemic Preparedness, Innovation, and our London School of Hygiene and Tropical Medicine, we are starting to deploy the second vaccine in areas at risk in DRC. So that's again, it's a tool we did not have even last year.
Well, Dr. Piot, thank you so much for your time.
No, thank you. Pleasure.
All right. Thank you all for listening. Thank you to Dr. Peter Piot. That was great. And if you are a new listener to the show, welcome. You can go to globaldispatchespodcast.com to check out our robust archives. Global health is a topic that I often come back to time and time again. It is such an interesting field and a key driver of global affairs. And if you are a returning podcast listener, thanks for keeping on listening. I have some great shows in the hopper for you. Bye.